Good evening, everyone. I welcome you to the today's Journal Club. The topic which was selected for this Journal Club is a very relevant topic which we most often face in our routine practice, which is post-operative urinary retention, especially in the inguinal hernia surgeries. And so Samir will discuss that whether there is any use of pre-operative routine catheterization versus no catheterization. Samir?
Hello. Yes, sir.
I welcome Ramkrishna sir also. Sir, good evening.
Good evening, sir.
Samir, start.
Yes, sir. Yes. Good evening, everyone. I'll be presenting the journal club. Today's journal club is on the journal The Effect of Intraoperative Urinary Catheter Use on Postoperative Urinary Retention After Laparoscopic Inguinal Hernia Repair. So these are the abbreviations which are used in this presentation. Uh, Coming to the details, today's journal is the corresponding author is Dr. Aldo Fofas, the assistant professor of general surgery at Cleveland Clinic Center for Abdominal Core Health. This was the original investigation published in June 15th of June 2022 in Journal of American Medical Association with which has an impact factor of 16.81. So the study was a two-arm study with where one group had the intervention of catheterization and the other group had no catheterization. It was a 2-year study with focus on quality of life and following the concert guidelines. So these are the table of contents. I'll go to the purpose statement of the uh, proposed study. Is catheterization benign? So catheterization is a um, common procedure, which is a common practice which is done intraoperatively during lap inguinal hernia with the purpose of the use that it will decrease post-operative urinary retention, mitigate risk of bladder injury. But the risks of bladder injury has an incidence of 0.1%, while post-operative urinary retention has an incidence of around 0.4 to 22% according to studies. But there is no set consensus for urinary catheterization. Despite having no evidence of the same, 10 out of 11 surgeons will use urinary catheterization. Coming to postoperative urinary retention.
Where
Postoperative
where
urinary
did you
retention,
get Samir? One minute. Where did you get the data?
this journal, I have,
This journal. Okay.
yes, sir. Postoperative urinary retention is defined as inability to pass urine despite having the full bladder or requiring straight catheterization, indwelling catheter, or returning to emergency in view of inability to void within 30 days of surgery. So there are no RCTs which have been made to determine the urinary catheter, the use of urinary catheter in minimizing the postoperative urinary retention. Hence, the need of RCT was there in this study. The outcomes in this study were to determine the use of intraoperative urinary catheterization to decrease the incidence of postoperative urinary retention, to determine the bladder injuries which will between the two groups, urinary tract injuries between the two groups, and more importantly in the group where there will be postoperative urinary retention, and also urinary tract infections. The standards where the diagnosis of postoperative urinary retention was left to the specific institutes. So the study design was randomized clinical trial where one group had intervention, which is catheterization, and the other group had no catheterization. It was a registry-based study, American Hernia Society Quality Cooperative Registry study, where 6 hospitals and 11 surgeons were involved. So the inclusion criteria of the
No,
study
no,
included.
Samir, give us a
Yes, sir.
brief introduction how that randomization is done. You are just like
I'll come, sir. I'll
1
come.
when?
This after this, sir. Methodol.
No, you said it's an RCT. Okay,
Yes, sir.
tell.
It will there. The inclusion criteria include patients aged more than 18 years with elective hernia surgery, recurrent hernias, and also the patients who have underwent open hernia surgeries before. Initially, benign prostatic hyperplasia was excluded from the study, but later, to increase the generalizability of the study, it was included. Exclusion criteria had the patients who can't tolerate general anesthesia don't or can't consent to the procedure. So initially, the sample size of 488 was set with a difference of 5.5% from the non-urinary, non-catheterization group for the outcome that there will be a 5.5% decrease in the incidence of postoperative urinary retention from the non-catheterization group, and the power was at 80%. Randomization was concealed computerized randomization, wherein the after the induction of anesthesia, nurse will call a designated number, and the investigator will then randomize the patient and inform the surgeon, and either catheterization or no catheterization will be done. So, for the methodology, all patients were asked to void urine preoperatively. The surgical care improvement project protocol was followed for both the patients, in which preoperative antibiotics, preoperative parts preparation to clipping was done same for the both groups. Then randomization was done accordingly, which I mentioned. And after the procedure in the catheter group, the catheter was removed and supplement data was then entered into the REDCap database. So Bonferroni method, multivariate analysis, and also post-hoc analysis was done in this study.
What are those? What are those each?
Sir,
What is Bonferroni method?
Why is everyone silent? Um,
Samir,
yes, sir.
talk. You are presenting, no? What
Sir,
men?
it
Why
is
silent?
sir, for multiple comparison, it will reduce the risk of the false positivity by dividing the alpha, sir, for number of tests performed.
Can you explain it better?
So, because there were multiple secondary outcomes in this study,
Hmm.
for example, this urinary complication, bladder injury. So, to ensure that this did not lead to any false positivity, Bonferroni method was used, wherein the threshold of the statistical significance was compared.
Ramakrishna sir?
Oh, I'm sorry, sir. I don't know. I have not studied this Banfaroni method, sir. I don't know
Okay.
about it.
Ravi Shankar sir?
see, Bonferroni correction. What did you say? Say it a bit more clearly.
So, because there were multiple comparisons, sir, and secondary outcomes for subgroup and subgroup analysis. So to ensure that it won't lead to inflated false positive results, Bonferroni method was used.
I think you have not understood it properly. I don't think it is just for secondary, outcomes.
No, whenever there are multiple comparisons are there, and it is a kind of statistical correction which they apply, where they reduce the risk of false positives by dividing the significance level. We put that significant levels as 0.0.05 like that. No, by the number of tests which you have applied, they divide that and then they apply that correction to avoid the false positives.
Yes.
As far as I have understood, it is that.
Nikita, have you understood it?
Yes, sir.
Tell us then.
So technically, if we are having multiple hypotheses or multiple things to compare, so if in general, if there are two things to compare, if the significance is even minimal, it's fine, sir. We can just tell by 1 point this is greater than this or this is insignificant than this. But if there are 10 things to compare, the significance we should further decrease to a minor level so that we can tell the difference between the individual points, individual comparison hypothesis, sir. So that is the Bonferry method.
I think what Niranjan said is probably the correct answer. So whenever there are multiple comparisons, to reduce the false positives, you divide the alpha by the number of comparisons that you are making, so that you will reduce the false positive rates. So that is Bonferroni correction. Okay, what is post hoc analysis, Praveen?
Sir, it is statistical analysis done after study has concluded and data collected. Sir.
What do you do?
So after conclusion of data study, to show the outcomes, they'll be doing the subgroup analysis, which were not included initially in the protocol.
So, do you accept results from post hoc analysis?
No, sir.
Nikita, what is post hoc analysis? See, you have to start using the word protocol. See, whatever you do, whenever you start the study, protocol is the document which is written, and everything that you do has to be written in the protocol, and everything that you do has to be recorded in the recorded according to the protocol, and then you do the statistics and the analysis, what the primary, the endpoint and the secondary endpoints, all of these things have to be predetermined, so that there is no bias involved, so that you are assessing what you have set out to do. After you have completed the study and found that the results are not as per your liking or as per you thought it would be, then you do analysis to compare certain things to show that in this subgroup, for example, if an infection in diabetics is more compared to non-diabetics or whatever, subgroup analysis to show that the study actually showed that these results were there, that is called post hoc analysis. So basically, post hoc analysis is not considered statistically very sound, and also not the results of the post hoc analysis are not considered to be what shall we say, level of evidence that we attribute to post hoc analysis is very low, so that you don't take any of these conclusions seriously. Ramakrishna sir, anything to add, sir?
Yes, sir. The post hoc analysis is done as a afterthought.
Correct.
If we are not getting results as per our expectation, then they will add some of the other analysis to show that there is some result, to give some conclusion. So these conclusions should be taken with a pinch of salt. Sometimes it may be misleading. So that's why it is
Niranjan,
commented.
yeah, Niranjan,
Nothing, sir. Same. I agree with you.
okay,
We'll go
right.
on with the critique then.
Continue. See,
Yeah.
I think before we continue, see, I think Niranjan, myself, Ramakrishna sir, we always tell you people, whenever Bonferroni has come many times, but any statistical method is introduced or any statistical method is there, it is always good to just go through Mann-Whitney U test. It is there all the time, Wilcoxon test. and all these things, they come very regularly. And multivariate analysis, logistic regression, all these odds ratio. So what you do is every time you come across these terms, I think I do that because I see our memory as far as statistics is concerned is quite not very good, because we don't use it all the time. So it is good to just go through it, and if you do it 4 or 5 times, you will be able to at least understand what they are talking about. And if you don't do it, I think all of you will struggle like this. Okay, carry on.
Sir. So pros and cons until this.
Ah, who's going to talk? Ainas, have you joined?
Yes, sir. Yes, sir.
Tell us, did you listen to the paper till now or not?
Yes, sir. Yes, sir. Only
Okay, tell us
initial.
the pros and cons.
Sir, first is, sir, it's a randomized control trial, sir. The study design, that is a pro, sir. In addition to that, they like it is published in the JAMA Journal of Surgery, which has a good impact factor. Then, sir, they have they have done this registry-based data collection, sir. Because of that, there is like that will ensure that their collection is their standardized data recording, sir. And the it is conducted across 6 hospitals, sir. So even that will like enhance the study, sir. Like those are the pros, sir, that I thought of. And in terms of cons, sir, this one point wherein initially they excluded BPH patients and then later on included it, sir. That is what I felt was the con, sir.
Anything to add? Nikita, Praveen?
BPH was before taking the
Praveen, be
certificate,
loud,
they had it, sir.
be a little louder. We are not able to hear it.
Hello, sir.
Ah.
Sir, BPH before they taking the first patient itself, they were added, sir. So it won't be a con, sir.
Safety, I didn't understand. What do you mean?
Sir, I know, sir, that BPH they were included later, so it might be a con. But BPH as a criteria, they include itself,
Yeah,
sir.
I don't think it is a con, because after recruiting only one patient, they added that,
Sir,
thinking that it may be a significant problem and it will unnecessarily confound the study results. So they added it immediately. So I don't think that is itself a negative. Yeah, carry on.
Sir,
Anything.
one thing a little
Go
bit confused.
back,
What is that
Sameer.
registry based, sir? What does it mean? Registry based. I
Sir,
thought
they
registry
have
based
a
means it
usually
is
many
a
countries in Western Europe and US. I think they have a registry where each hernia repair will be registered across the country. Whoever does it, they will have the database of that registry. So it is that database, the whatever the records of that patient will be available in that registry. Am I
So
right, sir?
means
just like cancer
usually.
registry, sir. National cancer registry that these registries will be there, and there will be probably data points which are standardized, that every hospital which does any of these operations are supposed to record those data, and it is available for anybody to take the data and analyze if they want to. Of course, the data protection will be there, but if you follow the rules, you will be able to access the data. So that is the registry based. Antandre, by and large, the data is well kept anta artha.
Andre, how does it differ from regular RCT, sir? Registry based RCT and
And
our
regular
regular.
RCT, Andre, for example, there will be a data coordinator in your hospital, and if at all it's a multi-central trial, there will be a data coordinator among the hospitals, and that data will be collected by yourself. But here, every operation you do, but if you, for example, if you are part of this Karnataka state hernia registry, every operation every surgeon does, if whoever has enrolled themselves with them, will be, in the KSC, Karnataka State Chapter website, or, there is a special registry that is formed. So all your data is put into that. But but the regular RCTs, only the concerned hospitals will be doing it. I think, I don't think there is anything major difference. It is the same data collection, but here they have a registry, just like they have a cancer registry, which will record all the cancer patients, and then the data can be actually shared with amongst the, the whole country if you want.
So it
Okay.
authenticates the data more, sir. That's it.
I don't think it authenticates the data more. Why? If you collect the
Sir,
data properly, why, the only thing is, there is, I think there will be a
certified.
preset and a pre-agreed, data points that have to be entered into the registry. For example, you can't miss any data point, especially if you are entering into the this hernia registry or cancer registry. So I think that, so basically that is it. But if you are doing a study properly, you will collect all the data points, and there will be a data coordinator who will ensure that all the data points are entered. And if any of them are not there, from time to time, they will ensure that the data, whichever is lacking, they will be able to get it out from the case sheets or whatever it is.
Okay. And just regarding that BPH patient added, actually change in protocol is a weakness.
Is a
But in
weakness,
this particular
absolutely.
study, it may
Hello.
not be because it was done soon after
Only
enrolling the
after,
first patient.
yeah,
So in this
because,
particular article, it is okay. But
yeah,
in general, changing the protocol is not acceptable. It is a weakness
correct.
only.
Yeah, Ainas, what he said is right, but in this patient, what would have
Hmm.
happened is the damage, excluding patients with the enlarged prostate would do to the, the results of the study is lot more than the damage that the breach of protocol does, which is why they decided to include the BPH patients. You understood, no? Ainas?
Yes.
Yes, sir. Yes, sir. Yes, sir.
Yes.
Because this is a patient with, you are talking about urinary retention, patients with hernia which is close to the bladder, so all of these things. So if you don't include benign prostatic hyperplasia, it will be a huge confounding factor. So that is why they included it even just after the first patient. So ideally breach of protocol is wrong, but in this case it is acceptable. Okay. Anything to
So
add,
one more pro would
Nikita?
be one more pro would be blinding, sir. Patient is blinded to the procedure
Ah,
under which group he is in.
hmm.
So
Yeah,
what is the problem with that?
No, sir. Pro, sir. It's a pro.
Pro. Okay, okay.
From the patient's perspective, it's a pro because he's unbiased whether he's catheterized or not.
Yes, okay.
Yes.
But sometimes catheterization irritation itself can produce this
Yes,
thing,
sir.
retention.
Yes, sir.
Anyone else? Supreet and this one. You want to comment anything? Likit.
No,
Samit,
sir.
did they comment in a protocol whether after including the BPH, whether they're going to grade the BPH also?
No, ma'am, no.
Uh, Nitya, any comments?
Sir, one is the follow-up is a little less, like short follow-up period, sir. So that could
No,
be
for this,
considered.
why do you need short? Why do you need more follow-up?
you are only looking at retention of urine post-op, no?
Post-operative, no. In fact,
Okay,
they
sir.
have followed up for 30 days. That is also more. So when
Ah,
you're seeing post-operative means it is till the time of discharge or at least probably 1 week maximum. They have looked at for 30 days.
Okay, sir.
ah,
Uh,
go
Samir,
on,
Yes, sir.
Samir. Anything to add?
Sir, first of all, RCT, sir, and the protocol was robust. Sample size was
no,
good, sir.
start with the place of study and where is whether the topic is relevant, all those things. Then RCT and all that. Go in a systematic way.
Okay, sir. Yes.
Where was it done?
Cleveland
Where was
Clinic,
the
sir.
study done?
Cleveland Clinic, sir, US.
Yeah, so it's a reputed center. And
Yes, sir.
where is it published?
JAMA, sir, the highest
Okay, when was it published?
recent article, sir. 2 years.
When?
2022, sir, June 5th, 2022.
So it's not so recent.
Yes, sir.
It's almost 3 years old, 3.5, 4 years old. Okay, but it's published in a reputed article. Okay, then
Relevant,
topic,
sir. Topic is
the
relevant.
relevant topic. Okay,
Randomized clinical trial and um, they have included intention to treat analysis is there.
okay.
And sir, cons, the standardization, sir, because of multiple institute, the standardization how they made the diagnosis of BPH at what time, the postoperative urine retention at what time, what scans they did, that is not mentioned or standardized.
No, no, no. You're talking about three different things here. What do you mean by lack of standardization? With
Yes,
relevance
sir.
to what you're talking?
In relevance to postoperative urinary retention only.
So how did they diagnose postoperative urinary retention? Is your correct? No.
Yes, sir.
That's what you're talking about.
Yes, sir. Yes.
Okay.
Like what scans they did or like what management they followed after that, it is not standardized anywhere.
No, no. What was their this thing? Outcome criteria.
Sir,
You're
They have
right
did
that there is no standardization, but what was their outcome criteria? Whether patient had urinary retention, whether urinary retention rates were better when they were catheterized or not catheterized. That was the primary outcome, correct?
yes, sir. And
So you're
in
right that they did not have the like proper criteria of diagnosing postoperative, whether it was clinical, whether they did a scan, and how did they manage. That
yes,
is what you're talking about, right?
yes, sir. Yes, sir.
Is relevant with respect to secondary outcomes. Yeah, correct.
Yes.
Then
And follow up in view of urinary tract injuries and that takes a bit of longer time, sir. 2 months, according
no,
to
they are
studies.
not talking about the urinary management of urinary tract injuries. They are telling how many of them had urinary tract injuries.
Oh, okay, sir.
What was their outcome?
Yes, sir. Urinary tract injury, like diagnosis was the outcome, sir, between the
Correct.
two
So that
groups.
is enough, no, for 30 days.
Yes, sir.
In one of your initial slides, you commented on quality of life. But is it mentioned in the article?
There only
Assessing?
one score they had used, wherein there was a increase in scores from the patients who had been catheterized. They had higher score, which was like a bad in terms of scores, sir. Only that thing they have mentioned, but as a
What score
quality
it
of,
is? It was a quality of life score, is it?
yes, sir, yes, sir. American Urological Society symptom scores.
But
So that
is there a data on that in the article?
In the
In the result,
discussion,
we have to see whether
they
later you
mentioned
will
it,
going to
sir.
post.
They mentioned it, sir.
they have just briefly mentioned it. They have
They
not
just
given
only
mentioned as
one
a
line,
much of a
one
detail
single
about it.
line, stating that from baseline to 48 hours and 30 days.
30 days. It
They
is.
just
It is.
commented on the score,
Okay.
but they did not mention in the table
No,
or anywhere in data. Maybe
no
in the supplement
supplementary data
material
was
it is like
also done.
not there.
Okay. Okay.
So this is the concept diagram in where 534 patients were assessed for eligibility, 43 were excluded, and 496 were randomized into the two groups. Coming to the results, hospital stay technique in the use of mesh and postoperative urinary retention diagnosis had no difference between the two groups, and the mean intraoperative time was 57 to 90 minutes, and anesthesia used was general anesthesia. Post-operative urinary rate difference between the two groups had no difference. Bladder injury, there was no bladder injury in the whole study. And post-operative, there was higher use of crystalloids in catheterization group, which was significant. Further, post-hoc analysis was done, and these factors were found, which is anticholinergic drugs, presence of BPH in the patient, crystalloid volume, and age more than 65. All these factors had a significant p-value, but there was no association of urinary catheterization in this post-hoc analysis. Pros and cons for results.
No, I think is that how you is when the present the results. Yeah, it should be
You
a
have to
bit more
show us full.
detailed, no? The results. I think it's you have just mentioned it in 4 lines.
No, even introduction everywhere you have mentioned it very, very briefly. Actual way of doing a journal club is you have to ask for pros and cons after that materials and methods and inclusion criteria, exclusion criteria before statistics once, and then for statistics again, and then after results again. And results you have to show us in detail.
Sir, only these post-hoc analysis, the use of glycopyrrolates, presence of BPH, crystalloid, higher use of crystalloid volume, and age more than 65. These all
No, there
factors
are
were.
tables. No, they have shown. There are tables right in the journal article. Post-operative outcomes, multivariate logistic regression, all those things they have shown. Intraoperative outcomes.
In the consort diagram, they have shown loss of follow-up before randomization. Just go back to that slide. There, before randomization, 9 patients they have excluded, mentioning lost to follow-up. Before randomization, how patients are lost to follow-up?
So
Can
they
you
were assessed
explain?
for
Sir, I think
eligibility.
assessment for
They were not even
eligibility, they
included
have
in the
not
study, sir.
operated.
Not even included.
Assessed for eligibility, I think probably they came for surgery fixing or something, or once they said, okay, you're probably part of the study, they didn't come for surgery. That is what they mean for loss of follow-up, I think. That is before surgery, even before they
That's what
started the study.
usually follow-up and last to follow-up they occur after randomization. No?
Correct. But what they mean here is that probably that they have come to the clinic for fixing up the surgery or whatever, and then once they said okay, they want to be part of the study, they've said yes, and then they have not come back. That is what they probably mean by last to follow up. They're not clear, very clear, as you said.
Not very clear how. Okay.
Ravishankar sir?
No, even I got that doubt, but I don't know. I don't think they have clarified it properly.
And these 2 declined randomization after induction. Who declined, whether it is the surgeon or the patient?
When they are already anesthetized, how can they decline randomization? I think that's also very doubtful.
That's also not very clear.
Not very clear, these things.
And you're talking about opening intention to treat principle, Sameer. They have excluded because patient was opening while hernia repair after randomization.
Yes, sir.
So what any explanation for that? Why did you say then intention to treat principle was followed?
Sir, in the study, they have told that if contralateral hernia is found, then they have continued to follow up the patient. So I thought that is the.
No.
Sir,
What is intention to treat principle?
so both are different, no, sir.
Both are
Here
different. That is what
it
I'm
comes.
asking.
Uh,
I'm asking him what is intention to treat principle. I didn't
Okay, sir.
understand him. I thought he is. What did he mean at that time? Now I want to ask him because opening when hernia repair means still it was part of either the catheter or no catheter laparoscopy, and then they have converted to open. But if it was intention to treat principle, they shouldn't have like taken them out of the study. And no hernia found also. Again, they have done a laparoscopic procedure, right?
Yes, sir.
So if it is intention to treat principle, that patient also shouldn't have been excluded. Sir, Ravi Shankar sir.
Ah,
And how can one patient self-catheterize?
Self.
self-catheterization ಕೆಲವರು they will be taught about.
ಅಲ್ಲ in OT, in OT, in OT.
ಓಟಿನ ಅಥವಾ ಅವ್ರು ಆಮೇಲೆ ಪೋಸ್ಟ್ ಆಪ್ ಆಗಿ ಮಾಡ್ಕೊಂಡ್ರೆ ಏನೋ ಗೊತ್ತಾಗ ಅದು
Probably after discharge before 30 days.
Okay, that also
After
they're not very clear.
discharge, before 30 days, the patient has self-catheterized. So they have considered the indication for catheterization is questionable. No? So they have excluded. If a surgeon sees and say this patient needs catheterization, then it is retention. The patient himself has done, we don't know whether it is really retention or not. So probably that
Have
is
they
the
given
reason they
any
have
details,
excluded.
Samir? No,
No,
about
sir.
these things they have not given.
They have not given details about these
Oh.
things.
All of it is
Yeah.
probably our assumptions. Okay.
Now, Sameer, tell us what is exactly intention treat analysis. Have you understood it properly?
Yes, sir. Like the first, like after randomization, the patients when they are assigned to the group, whether they adhere to the protocol or they drop out, will still.
No, not dropping out. Drop out, how can you can't analyze them if they have dropped out. See, it is like, Nikita, can you tell us what?
Sir, yes.
Yeah.
Once the patient is included in the study, if the patient is changing the group or if the patient doesn't want to proceed ahead with the planned procedure, but in the analysis portion, patient will still be considered under the included group in the as per the initial protocol, sir. That is intention to treat per protocol. Intention to treat, yes, sir.
Forget, don't make mix things. Per protocol is different, intention to treat is different.
Yes, sir.
Praveen, can you tell us in a better way?
Yes, sir. It is to analyze. Hello, sir. Sir, it is to analyze all the patients based on their initial randomized group, whether the patient had received the treatment or not, sir.
Correct. So the patient, after being randomized to a certain group, will continue to remain in that group despite changes, whether the patient went through. For example, the commonest example I give, which is easier for you to understand, is if you are looking at patients who complications of patients undergoing laparoscopic cholecystectomy and open cholecystectomy, and some of the laparoscopic cholecystectomy group for bleeding or lack of clarity of anatomy or whatever, you convert them to open cholecystectomy. And if there are complications in those patients, you don't consider them as complications of open cholecystectomy. They will have to be considered as complications of laparoscopic cholecystectomy. So those patients who were randomized to laparoscopic cholecystectomy should continue to remain in that group despite them being converted to open. So that is in short what is intention to treat analysis. So you have to apply the same principle to everything. So for your clarity of understanding, I've given this example. Okay, carry on.
Sir, not only change of group, sir, even if patient is lost for follow-up or death occurs,
Yes.
or he is excluded because of a side effect of a drug, something like that. For any reason, if patient is not there in the final analysis, still the denominator will be the randomized number.
Here,
Correct.
example, that one patient self-catheterized should also have been included in the
Yes.
eventual listing.
Yes, sir. Correct.
Sir, but here they analyzed without the follow-up patients, sir. In the analysis, there is about the 239 and 247 patients instead of the 241 and 250, which were actually randomized.
So this is not ITT.
That is what we are telling. It is not in ITT.
Okay, sir. So no, sir. This two lost to follow up and 3 lost to follow up in the both randomized group after the procedure. Those were also excluded from the analysis, sir. Only 239 were analyzed.
I know. That is what we are telling. That is what we are telling. It is not ITT. It is not intention to treat principle.
Okay.
It has not been followed in this study.
Okay, sir.
Yes. Okay.
Pros and cons.
Nikita?
Sir, my main issue was that they did not grade the BPH, sir. Though the distribution is demographic distribution is equal in both the groups, what if the one of the group had a different composition of higher grade of BPH, because the results are equal? Maybe that contributed to that is my question, sir.
No, I didn't get your question at all. What is it?
So once they had included the prostatic hypertrophy, they should have also considered the grade of hypertrophy. That also should have been equally noted between the two groups, sir.
No, because it is randomization. How can they equally note? They can't note it. No, equally.
No, sir. That should have been randomized between them is what I'm saying, sir. Now BPH is equal between them. 42 in catheter and 43 in no catheter group, sir.
Correct. It is almost
BPH
equal.
patients. Almost equal. But what if one of them had larger, higher number of patients with larger, higher grade, sir?
No, that is
Like
what they have
out of
not
42
mentioned the
patients,
details.
yes, sir.
They have
That
not
is not
mentioned those
mentioned
details.
because it's one of the clearly significant contributing factor. That is what they completely avoided, because initially the protocol also they avoided it, but they included and they avoided the major portion of it.
That's what they have not given us the details. Whether they have actually done it or not, different. Have they done it differently? We don't know because they have not given us the details. Okay.
That is one of the factors.
See, Nikita, the grade of prostatic hypertrophy is relevant, but more importantly, I think, see, many times
Post-void that
central post-void they should have given central hypertrophy, will cause more, obstructive symptoms compared to lateral hypertrophy. So even patients with 22 grams or 24 grams with significant central hypertrophy will more likely to go to retention than somebody even with 45 grams or 50 grams, which has actually spread outwards. So the grade of prostatic hypertrophy is important, but whether it is lateral hypertrophy or central hypertrophy, that is more relevant in terms of urinary retention, especially in the post-operative situation.
Sir, I think if you want to avoid this as a confounding factor, you should do urodynamic studies and see whether they really have obstructive symptoms or no obstructive symptoms. In that way, they should classify. Just assessing by ultrasound, it may not give you the true picture. So probably that's why they have excluded. They had made this as an exclusion criteria, but later somehow they thought this cannot be generalized, so they have included again. There is little bit of confusion there.
Maybe because they had more patients with prostate, it's almost around 80, 86 or 89. They couldn't exclude. They would have lost a significant number of patients probably.
The criteria to diagnose prostate is if patient is on drugs for BPH. If they are taking that, then they consider patient has got BPH. That's all. That is the only criteria I think they have used.
No ultrasound also was not done, sir. That's what.
That's what, because ultrasound is not a real guide regarding the obstruction or clinical significance. Many patients have huge prostate without any symptoms. And as sir told, a small prostate can produce severe symptoms many times, even retention. So the ultrasound measurement of the prostate is not a clinical correct guide for the problem.
Only thing that he can that as Niranjan said is pre and post void volume. So that will definitely tell us whether they have prostatic whether the prostatic hypertrophy is significant or not. And second thing is additional factor like bladder wall thickening and bladder diverticula. All these things will tell us that the patient is having lower urinary tract symptoms,
And
LUTS,
also, I
So
think
obstructive. Yeah.
they have not mentioned about any patients with urethral stricture or whatever. Those
Yeah.
can also significantly contribute to urinary retentions.
so initially we were discussing changing the protocol. Is it a weakness or not a weakness?
So
So
now it
these
looks more
questions will
like,
come up. So
yeah,
now it looks
looks
like
more
it
like
is a
weakness.
significant weakness.
Yeah, yeah,
This will
correct.
happen because they have not included it in the original protocol. If they had included in the original protocol, probably they would have thought of all these things,
All these
and
things.
in the data also they would have included this.
Correct. I think that is it. So this shows you the importance of protocol. Every
Yes.
single thing has to be included. Otherwise, if you don't think of all the data points, actually the protocol, even for example, what ultrasound scan, the machine that you used and what probe you used, and if you have used any interventional thing, you have to give the maker of that particular instrument that you have used to perform that procedure, to perform that intervention. All of these things have to be included, so that if you've got significant results, somebody else wants to repeat that test in another setting, they should be able to acquire the same equipment, so that your results can be either you know what shall we say, copied, in the sense they can be dupe, they can what should I do, I'm not getting the word, they can replicate your results, or they can prove that your results are one off. So protocol is the most important document in any study, especially RCT and all prospective studies.
Okay. Anyone has anything? Nitya, Praveen, any
Sir,
comments? Any?
no, sir, I had the same doubts you covered.
Okay.
I mean, the results they have actually given elaborate tables, like the proper group subgrouping and all
Yeah.
has been done. That I think Sameer has not mentioned about how they have portrayed the results. So that I wanted to highlight, sir.
Yeah, that sir already told in the beginning
Yes.
only. This is not how we should present the data. Hmm.
I think
Sameer.
here one
Yes, sir.
doubt comes. There are significant difference in the bilateral cases between these two groups. But if you look at the operative time, both are similar, which is little difficult to digest.
Because there are different centers also.
Ah,
Because 11 is
and
11 surgeons, so operative speeds might differ, and then probably that is what is causing that this one dilemma.
so many bilateral cases are there. Still, the time is same, and the length of surgery sometimes affects the outcome. This particular outcome, retention. Very long surgery, very likely to get retention. It can be a confounding factor there in that.
Yes, yes.
And another thing is the size of the hernia. If they are very large hernias, and
Yes.
if you do a lot of dissection, likely that they may go into retention. If they are inguinoscrotal hernias or very large direct hernias where you have to do a lot of dissection in the space of radius, then chances of you causing retention is much more compared to a very straightforward simple hernia 2 centimeters or whatever.
And because he has not shown the table, it is difficult to comment. But I saw They have mentioned something like done under local anesthesia in one of the tables. Is it right?
Yes, sir.
If he had put the table, we could have picked up that. They have
181
mentioned
patients were under local anesthesia.
a few cases, no?
No, but
Sir,
that is an exclusion criteria. No, those would not fit for GA.
Sir, actually not under local anesthesia. Local anesthesia was
Local anesthesia was given. Yeah.
given to them.
In addition to GA. Were those cases operated under local anesthesia or local anesthesia given
GA
in
with
addition
local,
to GA?
sir. GA with
When
local.
patient is under
At
GA,
the
what
end
is
of
the need for
surgery, local anesthesia.
No, not like that. I don't think it is that.
No, sir, because general anesthesia 491 they have mentioned, sir. 100% of the patients had general anesthesia.
Then where is the question of local anesthesia?
Additional, sir. Additional tab block they mentioned. Additionally, local anesthesia was given. They have mentioned, sir.
Is it additional?
Additional, sir.
Why?
For the skin incisions, port site incisions.
That is what I think. There is no standardization, probably, but that is why there are so many options: local, tab block, and all those things. So that is where the proper protocol, if it was like initially proper protocol was done, and if they had stuck to that, I think these things wouldn't have like come to the notice there.
Why, Nikita? Why is the analgesia very important?
Sir, if patient is comfortable and not in too much pain, there is a very less chance of urinary retention, sir. Like it contributes to the.
Why? No, you are right, but why is that?
Sympathetic nervous system activation. Sympathetic nervous system activation.
Correct. So if the patient is in pain, the sympathetic overactivity causes bladder neck spasm. So they are more likely to go into retention.
Yes, Sameer.
Yes, sir.
Shows that ITT is wrong.
We told no ITT again. Previously also we told.
Yes, yes.
What is reliable? Sameer.
Yes, sir. Hello.
What do you mean by reliable?
Sir, the study itself, sir. Like we can.
How? Because we have picked up so many things, no?
Yes, sir. Now
And evidence based. What is evidence based? Talk.
Sir, actually in the hernia surgery, the hernia surge group, sir, in 2018 they had put a guideline that there is no evidence of urinary catheterization. There is no benefit of urinary catheterization in inguinal hernia group. So they were following it, but I mean they had the guidelines, but nobody, but 10 out of 11 surgeons were not following it. But here after this, like they have included in the guidelines in their Cleveland clinic.
No, man, but this study does. What do you mean by evidence based? They are not based this study on evidence. No, they are trying to show us whether there is any difference. Already, if there was recommendation that there is no use, then how can it be evidence based?
So based on that recommendation only, this like RCT were not done.
So there were retrospective studies and few prospective studies.
I know. I
Based on that,
understand.
they generated.
I understand that, Nikita, but his argument I'm trying to tell him that this study was not evidence based in the sense there was already a recommendation that it is of no benefit, but they wanted to create new evidence. There was no evidence to this, whatever the study has been done. That is what he meant, evidence based. So there was no evidence for this. That's why they were doing a new study.
Generation, yes, sir. Evidence generation.
So generation of evidence. So it was a novel idea, not evidence based. There was no evidence to this.
No novel idea.
You got it, Samir.
Yes, sir. Yes.
And what is this cost effectiveness?
Sir, the catheterization causing injuries there, and also visit to the urological OPDs, urological clinics later on had a effect on the patient's cost, sir.
No, pros. You said pros. Cost
Yes, sir.
effectiveness. What do you mean
Yes.
by that?
If no, sir, like without catheterization, if there is a decrease in the urinary tract injuries, so it will be cost effective.
No, have they studied that men? Have they showed them in the data? Have they showed it in that results that it is cost effective?
No, sir.
We are talking about this study, no?
Yes, sir.
And this study's results. So you have to tell us the pros and cons about this study's results. Sir,
See, I didn't understand the evidence base. I didn't understand this cost effectiveness. I didn't understand any of your pro points. It is definitely not ITT. What was reliable about it, I don't know. And cost effectiveness, as you know, we keep telling, you have to do a cost analysis to show that one group the costs were significantly less compared to the other. So that unless you do it, you can't say this is cost effective. The cons, I think,
and
uh,
multi-institution, why is it a con?
Sir, same that standardization which I had mentioned, sir.
No, if you had prepared the proper protocol and asked that everyone to follow that standardized protocol, everybody would have followed. It is not about multi-institution. It can be a con as well as a pro. Pro is that you get many numbers for the
Oh,
study. The problem was the protocol was not standardized.
yes, sir.
And blinding, why is it a con?
So I mean, like, no, initially it was just it is wrong, sir. Like because of the procedure, we can't blind the uh, doctors, like the surgeons and anesthesists object.
you are
Okay.
not clear. You're not clear.
No,
What
no.
did you say?
No, no, sir. I mean, it was actually in the pro, sir. I got it.
Sir,
See,
observer blinding couldn't be done, Anta, he meant, sir. But later we realized that observer blinding cannot be done because we have to know what we are applying.
No, but observer blinding here, it is impossible, no?
That's what, sir. That's what. It can't be done, sir. It's not like it's not done, is what he meant. Then later he realized that it can't be done.
Okay, so he is wrong. His point is wrong there. Blinding is not there. Okay.
No,
BPH, what?
observer can be blinded, patient can be blinded. Only surgeon cannot be blinded because probably he is only operating. He would have seen catheterization. Observer, because by the time retention occurs, the catheter is not there. So whether he was catheterized intraoperatively or not, observer will not know. So observer
I
is
think
blinded.
in
Patient
this
also
study we
doesn't
don't
know.
have that detail. Who observed? Who diagnosed?
Surgeon
That is
and
what.
observer is same thing is what we were considering, sir. They did not mention, but surgeon is the observer is it's what we assume,
If
sir.
it was a proper protocol, they should have told that the operating surgeon is different and the observer is different. And
Yes.
probably it was practically impossible to have a different observer in all 11 places and or same observer in all 11 places to avoid bias.
Yes, sir.
No, probably that's why they have mentioned registry based. They would have taken data from registry to see whether the patient had a retention or not within these 30 days. So that data they must have produced. What you said, observer cannot be blinded, that is wrong. Observer can be blinded. What cannot be blinded is the surgeon.
Surgeon. Yes, sir.
Okay. What is that BPH, Samir?
Sir, that presence of BPH, sir, it is Like because of BPH, are they going into retention or because of the urinary catheters?
I didn't get you.
Sir, because of the BPH, sir, they are because of the BPH only they are going into retention.
No, BPH we discussed, but what was your doubt? I didn't get you. What was your con in that
Sir,
BPH versus catheterization itself?
yes, sir. Is it because of the BPH itself or is it because of the catheter? Because they have not mentioned like the diagnosis, like grading and everything, sir.
No, no, that we discussed, but I didn't get your part where you're saying it is because of the catheter.
Sir, BPH
No,
itself
sir.
can cause
Probably what is
retention.
meant is if patient develops retention after say 15 days of discharge, how are you sure it is because of the surgery or because of BPH itself?
Okay. Is that what
How
you're meaning?
you
Yes, sir.
Because I didn't understand you.
Sir, is it the BPH itself or is the catheter which is causing to the retention?
Sir, Ravi Shankar sir, did you understand? I don't know. Is it
Yeah.
again contradicting?
Yeah, I think what is I think he's probably thinking in the right lines. So if the conclusions they draw is because of the surgery, post-operative retention due to surgery, then the BPH should not be a contributory factor. So for that,
No,
as
no. He is not talking about surgery. He's talking about catheter.
that's what post see this the
Whether
surgery.
catheter cause retention.
Catheter cannot cause retention. Surgery causing retention.
He's insisting on that catheter caused
Uh,
retention. That is why I'm not understanding
no,
what he's
no.
meaning.
So no,
Surgery,
Samir,
I got it.
Sir,
Samir,
catheterization during the procedure, sir.
Samir, the thing is, it should have been if BPH was included as per protocol, as Ramakrishna sir said, they should have then thought about the various grades and also the symptomatically to correlate with and uroflowmetry and all these things have to be done so that so you include you can classify these patients accordingly so that you can show that confounding factor of prostatic hyperplasia is not playing a role in the post-operative retention of urine. So that they should have done, but they have not done it. So it is a negative, but not for the reason that you are thinking. Okay, what is gender?
Gender.
The study was more male, yes, sir, based. So
Because
we can't
hernias
derive.
are more common in men, no? So that is the reason.
So why is it a con?
Sir, we can't derive the this one. How to say?
Huh?
We can't derive the outcomes, sir, like from the study itself. That is it, like
What outcome?
sir, will it be applicable to the female group also?
No, they are not talking about any male or female group. No, they're just speaking about inguinal hernia surgery catheterization, whether it leads to urinary retention or not.
no, sir. Excuse me.
Sir.
This is called gender bias. Gender bias is there because majority of the patients are male patients only, and the conclusion derived out of the study can it be applied to female population also? That is questionable. If
Yes,
conclusion
yes.
says there is no use of catheter in male patients, it is acceptable. If he says there is no use of catheter in general, then this becomes questionable whether the conclusion applies to female population also is unanswered in this study. That's what we call gender bias. In the bias, so many types of biases are there.
Yeah.
This is one of the bias. It's a gender bias. So that gender bias is there in this study. So that he has put it as a concept. Actually, these authors themselves have mentioned in the limitation.
Yes. What is the PU or difference?
Sameer, come
Hello.
on, talk,
Sameer,
man.
Sir, post-operative urinary difference, sir, between the two groups, it is not like so significant, sir.
So
Only
so
that is an observation. So how can you call that as a con? See, Sameer, you have to think this through properly. If you don't understand some of the things, discuss it with your seniors, or if you finally if you can't get the answer, discuss it with either whoever is the moderator or me, whoever. You can't just come and put up things like this without knowing the answers to any of these things. This is not how a journal club is done. You've given a very good example of how journal club should not be done. From the word go, it has not been a good one. So you need to buck up your act. You have any collateral reading or have you finished?
yes, he has. I think that also there is a problem. Anyway, go on to show. Tell us.
yes, coming to the discussion, urinary catheter is a common practice, and due to this surgical dogma that extensive dissection in the space of ridges, the urinary catheterization will minimize the bladder injury, but there is no evidence to support this. Hernia Search Group in 2018 had specified guidelines mentioning that there is no role of catheter in minimizing the bladder injury. As of for bladder injury, the study, like in the study which in this journal, there is no bladder injuries in both the groups, but bladder injury itself is a rare complication. About 0.02% in large study groups done worldwide, wherein out of 5,017 patients, only one patient had a bladder injury. Uh, um, there is a decrease in QL score in patients after catheterization. American Urology Society of symptomatic score, they had a increase in the score, which suggests the decrease in quality of life from baseline to 48 hours to 30 days. The limitation of this study, which are like pre-avoiding of all the patients, did the pre-avoiding itself help in minimizing the bladder injury?
But they have done it in both groups, no?
Yes, sir.
So it cannot be that.
Yes, sir. So this is the symptom score of American Urological Association. For crystalloids and anticholinergic drugs, as we know, glycopyrrolate, which is a anti-muscarinic. It inhibits the inhibits the muscarinic receptors and to prevent bradycardia. But this inhibition can adversely affect the genitourinary system, causing bladder hypertonia and leading to increased risk of post-operative urinary retention. Intravenous fluids, according to the study, more intravenous fluids have been mm, um, the outcome is there is low post-operative urinary retention. Further studies about these modifiable factors should be done to determine the um, association between them and the post-operative urinary retention. According to the study, use of intraoperative catheter had no role in reducing the risk of post-operative urinary retention in patients undergoing laparoscopic inguinal hernia repair. So these are the related articles. The retainer study in which they had mentioned that urinary catheterization itself caused urinary retention in patients, and also this the meta-analysis which
No, no,
suggests
no, no. Sameer, When you
Yes, sir.
show us collateral reading, you have to show whether what was that, whether it is a review article, meta-analysis, a retrospective study, prospective study, how many numbers were there, what was the like primary outcome which they wanted to do in that study, and what was the eventual result. Tell us no. If you keep silent, you can't keep silent in your own class.
We already
Sir,
overrun by 15 minutes, and we have not done proper journal club also.
this
You what you know or you don't know. You just cut pasted that the title and this thing. Have you gone through that paper?
this meta-analysis,
Speak up.
sir. Hello?
Speak up, or you're looking at it now.
No, sir. This meta-analysis suggests
Which
uh,
one is meta-analysis?
this
Previous
one,
is
sir.
what?
Previous
Previous
is a
study is what?
retainer for this one, sir.
What is it, man? You know or no? You don't know. Have you looked at the paper or you just put it up? Talk. You can't keep silent. You can't check this thing. Go back and check it now in the class.
So this was a retrospective study, sir.
Prospective.
Which which suggests that like the urinary
I don't
catheterization
think you
itself.
have read. I don't think you have read. Okay. Anything else you want to tell us? Nothing, no?
No, sir.
Okay. Comments from students. Aina's is
So
there or
yes, sir. Yes, sir.
yeah?
I'm there, sir. So just regarding the like the analysis part, sir. Like if there was more description on that, sir. Like after like the results portion was a little unclear, sir. Like
No, you're
in
talking
that.
about study or you're talking about his presentation.
So in terms of the study also, sir, like because the charts were not there, and like in terms of the study also, like they haven't drafted like a proper protocol, sir, so as to follow it. So we cannot comment
Okay.
on changing the practice based on that.
Okay. And about Samir's presentation preparation.
I think we'll let some seniors comment on that.
Okay, Nikita.
Sir, it was a very haphazard presentation, sir. He knew about few points. He doesn't know about few points.
Not few points, many points. What he has put it up, he himself doesn't know. That is the basic etiquette of a scientific presentation. If you don't know, you shouldn't put it up. Okay.
Yes, sir. But
And he had enough and more time to prepare for it.
Samir, we understand journal club is the most difficult one to do amongst all the other presentations. But for that reason, you have to put in more effort, consult more people. And I think Niranjan wouldn't have said no if you had asked him certain things that he would have probably guided you. Or if you had come to me and shown me the presentation, I would have guided you. I
This
think,
time I didn't help him basically because he picked up the papers probably 4 or 5 days or 1 week before the journal club, and he didn't shortlist. Second, once the paper was shortlisted, he didn't come back to me whether presentation is there or not there. He didn't show the presentation, and he himself had planned to change the class. So I think everybody they have forgotten that it has to be shown at least 1 week in advance. And for journal club, they will have notice of at least 1 month. They should start finding the papers at that point of time, not 1 week or 4 or 5 days prior.
Yeah.
And there are enough and more journals, and he can't give the excuse that there is only one journal with 3 articles available. So that
So
is why I
Sameer,
didn't help him this time.
Sameer, it is, not to discourage you, but this is not the way to do a journal club. Okay, you need to be a bit more
You
serious, take it more, seriously, and put in more effort, because journal clubs are difficult and lot of things you
Yes,
can't
sir.
understand. But
And that too, it was a very, 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 very common and basic topic. It
hmm,
didn't require too much of science to understand things here. Sir, any
okay,
your final comments? Yeah.
yeah, Ramakrishna sir,
Yeah, nothing, sir. You given all the comments. Nothing to add there.
yeah, okay.
About the study, sir.
I think
Study, there are a lot of policies. The firm protocol is not there. That's the reason why these problems came up. And the moment they say drugs, this still ACH inhibitors, that's not the only drug which can cause retention. Other drugs
Yes, sir.
also can be there. And there are other reasons of retention of urine. Those things also to be considered, either included or excluded or distributed. Something they should do. So in the introduction, they have to mention all the causes of acute retention and how they have dealt with each of these factors. That introduction part is lacking there. And because they changed the protocol, it led to a lot of confusion.
Yes.
so. I don't think we can take the findings to be of any significance. We should,
Seriously. Yeah.
yeah, avoid,
And I don't know
await
how this
better.
got accepted in JAMA, because
Ah,
that is
And that too,
very
and
high
that too, it was done by
quality. This
Cleveland
one very.
Clinic.
Mm,
ಕ್ಲೀವ್ಲೆಂಡ್ ಕ್ಲಿನಿಕ್ ಅಂತ ಎಕ್ಸೆಪ್ಟ್ ಮಾಡಿದ್ದಾರೆ ಅಷ್ಟೇ.
mm, Cleveland, yes. They are also biased.
ಹ್ಮ್.
Okay, sir. I think, yeah,
Sir, just
Samir,
like
not to
sir,
discourage you,
activate,
but
sir, if you remember, activated protein C ಅಂತ ಒಂದಿತ್ತು, and that was published in New England Journal of Medicine, and everybody thought that is the next best thing than sliced bread, and in terms of preventing sepsis, and everybody started giving it, and a lot of patients died because of bleeding, and that factor had not been considered at all.
and also it was costly. It was around some 2
Very
lakhs or 3 lakhs, I think.
2 lakhs or 3 lakhs, and it was a bad. I don't know why NEJM accepted it, but after that nobody were able to reproduce it, and then it has died a natural death. But sometimes these things can happen. Okay, good night everybody.
Okay, sir. Good night.
Good night,
Samir,
sir.
Okay, good
not to
night.
discourage you, but you need to buck up. Okay, you can't give us the excuse every time for every presentation. Okay, good night.